no one has questions, let's segue over to HIV in the kidney. And then I think our last GN that we need to cover two more GNs, TMAs, as well as the MPGN and infection-associated GNs, and then we're done with GNs. My goal would be to finish this all this week. So I have another session with you guys on Friday. So I'm going to try and move reasonably quickly through some of these topics. Any questions before we move on? Okay, let's then take on HIV in the kidney. Certainly, we talk about glomerular diseases, and one high point in that discussion is HIV, but I want to talk about other glomerular diseases. The other main category of glomerular disease is the so-called HIV-associated immune complex disease, and some would use immune complex kidney disease, abbreviating this as HIV. As another category of glomerular disease, you can have thrombotic macroangiopathies, and then you can also even have tubular interstitial disease, which we're not going to cover in great detail. The other main category that I want to cover is what these heart therapies do that the nephrologist must be aware of. There's a variety of angles to that part of the discussion. So with that introduction, let's take on the glomerular diseases first. First, let's review pathogenesis. And one feature that I want you to be aware of in pathogenesis is that HIV is infecting you can find HIV genome in all components of the nephron, including endothelial cells. You can find HIV genome in the mesangium. You can find it in the parietal epithelial cells, which is the Bowman's capsule, right? Visceral epithelial cells or podocytes. You can certainly find it in tubular epithelial cells, and of course, the infiltrating macrophages and lymphocytes. Now, it makes sense that it's present in lymphocytes and macrophages. If you recall, HIV primarily infects the host through T cells, engaging various T cell surface receptors, but it also does have the capacity to integrate into these other cell types. We'll talk about that as we cover HIV in an upcoming formal lecture. But HIV can get into all of these subcomponents of the nephron. Why is that relevant? Is because when we talk about collapsing glomerulopathy, even though the name implies that this is primarily glomerulopathy, you can see changes throughout the nephron, including in the interstitium. So it makes sense, based on this point regarding pathogenesis, that there are manifestations of HIV-associated kidney disease involving all components of the nephron, okay? You often see hypergammaglobulinemia, which can potentially explain the high VIC, right? An immune complex kidney disease is perhaps understandable when you see this generalized immune activation that can happen despite this being overall an immune suppressing condition. This immune activation also predisposes to HIV patients getting a variety of autoimmune diseases or autoimmune manifestations, okay? And you can see these autoantibodies circulating. And then there's the genetic background that we focus on in particular with APOL1 risk alleles. And having two APOL1 risk alleles increases the risk of collapsing glomerulopathy with HIV something like 30-fold. It is a potent risk factor. Now let's talk about HIV-associated collapsing glomerulopathy, also called HIV. Again, this does have this distinctive interstitial infiltrate, once again, highlighting the involvement of HIV in the pathogenesis through effects on all components of the nephron, including tubules and infiltrating interstitial lymphocytes. And then you'll have the collapsing glomerulopathy. This is a good example of it on the left side, where you can see, again, this crushed glomerular tuft, and then Bowman space filled with cells. The main differential diagnosis for this histologic finding would be of a crescent, such as, an ANCA-associated vasculitis. When you can see some of these gaps in the Bowman space, especially separating this increase in cells from Bowman's capsule, that would be more aligned with collapsing glomerulopathy. Think of this as sort of an explosion outward from a dedifferentiation of these podocytes and an increase in cell number. So the feature of this podocyte is one that looks quite abnormal. Often these cells are larger than normal sized. Often they have protein resorption droplets present in them, and they're increased in cell numbers. So hypertrophy and hyperplasia, these de-differentiate and increase in number. And then again, you can see protein droplets in them as well. Sometimes they have a foamy appearance to them. Those would be features that would help you potentially discriminate these from the crescents. Okay. Now, the other frequent feature that I'll highlight is present on this right-hand side, where you get this de-differentiation and increase in cell number that occurs in tubular epithelium. Okay, so not only in podocytes, but also in the tubular epithelium. And so that manifests itself by enlarged tubular structures that often have these proteinaceous cell casts that are present throughout. And then again, you often have a pretty intense interstitial infiltrate. So again, let me say one last time, collapsing glomerulopathy is also a tubular interstitial disease. The clinical presentation is classically or most commonly associated with those of African descent, and that is because of that APOL1 risk genetic background. And so this is the most common pathology that you're going to see in a Black patient who has HIV and proteinuria, unless, of course, they also have diabetes, an alternate diagnostic possibility. But again, proteinuric kidney disease in a Black patient with HIV, HIVAN is really a very high likelihood. Usually these patients have full-on AIDS, that is to say, not just HIV infection, but also profound degrees of immunosuppression as well as viral replication. So this is, again, usually a late stage of disease, one in which, again, you have really low CD4 counts and high viral replication, though it is described in early infection as well. Okay, but that's not the most common presentation. Often there's a significant impairment in GFR, and you can imagine that given the histologic features that I've highlighted, both tubular interstitial and glomerular. There's often a degree of nephromegaly, so diabetes, amyloidosis, and HIVAN are some of the most common sort of things that we think about when we see a patient with nephromegaly. Okay. And there is a correlation perhaps between that nephromegaly and the degree of interstitial infiltrate. So there's often an increase in cortical echogenicity as well. Interstitial infiltrate is often present, is often a histologic correlate of some of these radiologic findings of increased echogenicity. Treatment is generally the prompt initiation of heart therapy. There is also evidence suggesting that ACE inhibitor therapy has protective effects even in mouse models of HIVAN. And then the question of whether to use steroids is one that has evolved over time. We used to be much more enthusiastic with implementing steroid therapy for HIVAN. However, with more potent heart therapies being available, where you can get suppression of viral replication quite promptly, There's, I would say, in general, less enthusiasm for the concomitant use of steroids with introduction of heart therapy. I would still use it if I have significant renal impairment. If I had a patient with a creatinine of 3 and heart and high van, or higher, that was an arbitrary number. I don't have a hard cutoff. I wouldn't be just saying, just start your heart and let's wait several months before these lesions regress. Unless there was a contraindication, would institute steroids at that time and look to taper them rather quickly, according to the change in renal function. If, however, someone had relatively preserved GFR, with just primarily nephrotic syndrome, I would personally just use heart and not much steroids. Okay, so think of it as an accelerant in the renal recovery, but it has to be, of course, paired with heart therapy. Moving on to the other branch of glomerular disease that you can see with HIV is HIV or HIV-associated immune complex disease. And the most common form of this is a lupus-like nephropathy. What is it? What gives it this name, lupus-like nephropathy? Well, it has features of lupus nephritis, such as full house staining on immunofluorescence, right? And then it also would have no clinical evidence of SLE, negative ANA, no signs or symptoms of lupus. This is thought to be the second most common glomerular disease that you're going to see with HIV after HIV. Okay? You can certainly see other glomerular diseases, including IgA nephropathy, membrane, and that may be because of not only the autoimmunity, which we highlighted, that can occur with HIV infection, but also these mucosal infections that HIV patients commonly get, right? They're often having diarrheal illnesses with various parasites, or so this may be again a multiple hit disease, not just autoimmunity, but also the impaired mucosal defense that comes with HIV infection. Membranous nephropathy has been described, MPGN, certainly, and sometimes this is in the context of HCV co-infection, which is common in HIV patients, but MPGN with HIV alone has also been well described. A nondescript mesangial proliferative GN, and then some of these organized deposition diseases, which we've talked about, are also associated with HIV. Moving on, TMA is another feature of HIV that is well described. Some of these are from the autoimmunity again of, in this case, production of an autoantibody to Adams TS13. And then usually these patients are profoundly immunosuppressed. So the largest case series of TMA with HIV is in the context of patients with advanced AIDS. There's other glomerular pathologies that are described. Some of these are related to secondary infections. Some of these are from the downstream metabolic diseases that are now well described in the HIV patients that are living longer and longer. So many patients with HIV have some of the usual things like diabetes, and patients with HIV can certainly get diabetic nephropathy unrelated to the HIV per se. Okay. Moving on to this quick conversation about heart therapy for the nephrologist that I'd like you to know is that, I think it's always useful to know what's happening on the other side of the fence so that you can align with your colleagues in other disciplines as you're managing the kidney disease. So we've gone over, in oncology and in myeloma, knowing how your BMT colleagues respond to various signals in myeloma is important. What they're thinking about when they're thinking about therapeutic options, that's important. So similarly, I'm giving you a little bit of background knowledge of what your infectious disease colleagues are thinking when co-managing these patients along with you. Whereas when I was a resident, we held back on the introduction of heart therapies until you had a low enough CD4 count. That is not the modern practice of HIV treatment at this point in time. Really, heart therapies is initiated essentially in anyone who's willing to take the drugs and is compliant, and that not only reduces some of the morbidity to the patient, but also has some public health advantages by reducing disease transmission in the community. Since we have numerous options and they have less toxicities, the threshold for treating patients has become favorable, such that everyone is offered treatment if they take their drugs. There's a variety of drug classes to be aware of, and this continues to grow. The old, um, uh, nucleoside reverse transcriptase inhibitors and non-nucleoside reverse transcriptase inhibitors plus protease inhibitors. That was sort of the three-pronged approach for most patients, now has been expanded to include other angles of approach for inhibiting viral replication. So I've highlighted a couple of them here. But again, this was really the three-pronged standard back in the day: nucleoside reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, and protease inhibitors. So most regimens in the current practice include these nucleoside and nucleotide reverse transcriptase inhibitors, the so-called backbone, two of them, and then you add a third drug. And the choice of that third drug can be a variety of these other classes. Protease inhibitors are a common one. Often these protease inhibitors also inhibit the CYP3A4 enzyme system. That is intentional, and is described as called boosting, in order to get by with less frequent dosing of your other heart components. Okay, so again, these boosters used to be, ritonavir, a common element of the heart regimens. Now you'll see cobicistat as another not uncommon element of these regimens. Cobicistat has no antiviral effect. It is primarily just used to boost the drug levels of the others so that you can get by with less frequent dosing. Okay, this is relevant because you need non-protease or non-cobicistat containing regimens when you're managing patients who also need calcineurin inhibitors, the classic of which is the HIV positive patient who undergoes kidney transplantation. You have to get them off these drugs. Or, if you're managing a membranous nephropathy that you're thinking about calcineurin inhibitor therapy, you'll need your HIV colleagues, your ID colleagues, to get them off these boosters so you can safely use these drugs. These are very potent inhibitors of CYP3A4, such that if you tried to co-administer them, you'll be giving something like once or twice a week doses of tacrolimus in order to get reasonable drug levels. Okay, the renal effects of heart. Okay, there are primarily two broad categories that I'm going to highlight. I'm going to say other for one of those categories, sort of a big, wastebasket of possibilities, which I'll get to, and then the mitochondrial toxicity. So let's go over this phenotype of mitochondrial toxicity that you can see with these patients who are on heart therapies. Well, the pathogenesis revolves around these nucleoside reverse transcriptase inhibitors inhibiting mitochondrial DNA polymerase. Okay, so NRTIs have their antiviral effect by inhibiting DNA polymerase driven by the HIV virus, but also have a spillover effect on mitochondrial DNA polymerase, such that they cause, in some cases, with cumulative dosing and in certain patients, a mitochondrial dysfunction. Okay, so if you understand that pathogenesis, you can then intuit some of the disease manifestations that you can that are revealed with this condition. So mitochondrial dysfunction can certainly result in impaired oxidative phosphorylation, right? We've gone over this in our acid base. I don't have to reflect back. If you don't have normal electron transport chain on the mitochondria, then you'll have these afferent energy production pathways that don't require oxidative phosphorylation that are unopposed or active, and you'll get an accumulation of lactate. So lactic acidosis is a feature. And sometimes this is mild and subtle. So you can have patients that are on NRTIs that don't feel terribly bad, but have this little bit of metabolic acidosis that has a mild anion gap elevation, and you can truck along for months and years with this form of metabolic acidosis. Pancreatitis, myopathy, hepatic steatosis are other features of this. Some of these individuals would also have a lipemic serum. So they have really high elevations of triglycerides. Remember, again, from our energy pathway discussion, you need fatty acids to enter the mitochondrium in order to shuttle these to ketones, for instance. And so if you have mitochondrial dysfunction, you can get an accumulation of fatty acids and triglycerides, resulting in hepatic steatosis as well as transaminitis and lipemic serum. You can develop the myopathy related, again, presumably to impaired energy metabolism. Pancreatitis, it's not well understood how that develops. Maybe that's from the hypertriglyceridemia or from a direct toxicity to pancreatic function from mitochondrial dysfunction. Here are the risk factors: prolonged use of NRTIs, in general, smaller patients, and females would be generally smaller, pregnancy, obesity, co-administration with other drugs that can affect mitochondrial function, including metformin and ribavirin. Okay. There is a relative risk according to the NRTI that's chosen. The most common NRTIs that you're going to see now are emtricitabine and tenofovir. These are generally lower risk, but still cause this disease. That can cause this disease. Abacavir you'll still see in certain patients. Lamivudine is an oldie, but we'll still see it occasionally, including in the treatment algorithms for treating hepatitis B. So theoretically, you can also get this mitochondrial dysfunction in patients on lamivudine for hepatitis B therapy. Treatment involves withdrawing the heart therapies rather quickly, and then some people give, some cofactors and vitamins, including carnitine, to try and turn the corner on this that have unclear benefits. Okay, primarily you need to stop the heart. Okay, by the way, it may take quite a long time for this mitochondrial dysfunction to resolve. I've had patients die of overwhelming lactic acidosis, even though they stopped the heart therapy. They have lactate that they continue to generate on CRT. The reason is because, remember, this is inhibiting DNA, mitochondrial DNA production. And so just stopping the heart therapy does not immediately restore normal mitochondrial DNA synthesis, which then requires, transcription and translation into intact mitochondrial enzymes, right, and proteins. So it stands to reason that it's not something that can resolve in a matter of just hours or days. Okay. All right, so let's talk about the other category of heart effects that are relevant to the nephrologist. We've talked about cobicistat and its effect on creatinine secretion. That is pretty, profound and predictable. So this classically manifests as an increase in serum creatinine with stable blood urea nitrogen, similar to the effect of trimethoprim. There are effects on creatinine secretion by some less common, by some other elements of heart therapy. Dolutegravir, you can see in common regimens of heart, but it's less potent when compared to the effect of cobicistat. Proximal tubulopathy is an older feature of heart because we don't use this form of tenofovir as commonly anymore. Tenofovir disoproxil is this first generation formulation of tenofovir, but about like 5 years ago now, uh, there was an introduction of another form of tenofovir, alafenamide, which doesn't seem to cause this proximal tubulopathy. You can see very mild degrees of phosphate wasting with tenofovir alafenamide if you look very hard, but it is really uncommon. With tenofovir disoproxil, it was essentially universal. Mild degrees of phosphate wasting were universal, such that patients on disoproxil should get DEXAs done periodically because of the chance for progressive bone loss from proximal phosphate wasting. Nephrogenic DI is associated with, again, tenofovir disoproxil, but is an uncommon manifestation of that. ATN, again, can be a manifestation of tenofovir. You can see that tenofovir is a generalized tubular toxin resulting in tubulopathy, proximal tubulopathies, distal tubulopathies resulting in nephrogenic DI, and then ATN at high doses and with typically with concomitant tubular toxins. Interstitial nephritis is described with abacavir in particular. You shouldn't see much of that because standard practice in treating patients with abacavir is checking for certain HLA loci that confer this increased risk of allergic reaction. So everybody who's about to be treated with abacavir gets this HLA uh, um, uh, test to ensure that the risk of hypersensitivity to abacavir is rather small, but it is described in the literature. Chronic interstitial nephritis was associated commonly with indinavir, as was crystalline nephropathy. However, this is a really uncommon element of this protease inhibitor is really not used anymore in modern practice of HIV treatment. But I mention it primarily for historical knowledge. Nephrolithiasis is really uncommon when, well, drug-related nephrolithiasis is uncommon, right? So there have been descriptions of these HIV meds, some of which are insoluble in the urine, causing kidney stones. But again, these are very uncommon kidney stones. And the more common manifestation of nephrolithiasis in an HIV patient is just a typical calcium oxalate stone or a uric acid stone in somebody who has chronic diarrhea related to enteropathies. Remember chronic diarrhea we talked about? I used actually um, ostomy patients as having risk factors for uric acid stones by virtue of the chronic metabolic acidosis resulting in aciduria and then the low urine volume. So again, kidney stones are not uncommon in HIV patients. The drug-related kidney stones are a very uncommon subset of that disease expression. Okay.